Hello, everyone, and welcome to our January 2023 question and answer session. I wanted to thank everyone for showing up and joining us today. We've gotten a lot of really good questions, and I have with me today Cindy Kraft. Cindy, you want to say hello?
Well, thank you for joining us today. And as I've been saying, happy 2023 and the go live of Oasis.
We have an entire list of questions today, Cindy, and believe it or not, they are not all Oasis E. I'm shocked.
That's a good thing. I mean, I think there's a lot of other things that we want to make sure people haven't lost track of in all of their diligent prep work for January 1.
Yeah, all of their diligent prep work for 2021. But everybody's doing great, right? I mean, you're here, but I'm sure everybody is just thrilled with the Oasis E.
Let that
Okay.
hang for just a little bit.
Yeah, we'll just let people just listen to that for a second. And it'll be silence and crickets. I want to remind everyone that if you have any questions or if you have any comments that you'd like to make, please use the Q&A box, and it comes directly to us. And we would like to answer as many of those as we possibly can today. But we had some questions that were pre-submitted for the session, so we'll start with one of those. And it will not be an Oasis if that's okay with you, Cindy.
That's fine with me.
Okay. I love this question because we run into this all the time, Cindy, and it's about homebound status. And
Okay.
the question is, I occasionally find it challenging to decide if a patient is actually considered homebound. For example, I saw a patient today who lives in a memory care unit in an assisted living facility. They are able to ambulate greater than 300 feet with assistive device with no fatigue. However, they do require supervision due to dementia and some balance deficits, making him a I'm sorry, my dogs are going to bark in the background because that's just how it happens. However, making them they have some balance deficits, making them a moderate risk for fall. From what I understand, they do not qualify under criteria B, part 2, which states leaving the home requires considerable and taxing effort. Thoughts on that, Cindy?
Well, let's kind of peel the layers of this. I think that, one of the challenges of confirming homeboundedness is specific to dealing with patients that live in assisted living facilities, because it creates a situation where you look at it and say, okay, there are some services available potentially. This isn't quite the same as someone's own home. Expectations around where they need to get to and how they need to get to certain places all need to be taken into consideration. So I think it's critically important. First and foremost, we remember that homebound is a qualifying criteria. Homeboundedness is one of several elements that have to be met for the person to receive skilled care at home. It's not intertwined with the issue of, do you need a nurse? Do you need a therapist? That is a separate issue. This is, does this person meet a fundamental qualifying criteria to receive services in their home setting? Now, some of you may say, I already know that. So why are you repeating, that piece of it? Because what I'm finding is a lot of frontline clinicians don't really understand it in its proper context. That this is not about, do they have an impairment? Do they have a disease process? Do they need med teaching? That's a separate issue. Homeboundedness stands alone with respect to, do you get to have these services come into your home environment? When we're looking at an ALF situation, we always have to remember that this is their home. It may look and feel different than a freestanding home or an apartment, but it's the same situation, regardless of what services may or may not be around them that they're paying for as part of being in assisted living. This is still their home. And so we have to look at each individual situation and say, can this person meet these criteria or not? So if we look at the example within the question, first of all, the ability to walk a certain number of feet is irrelevant when we're talking about meeting homebound status. Okay, I want to be very clear about that because we see referenced in the question that they can walk more than 300. What I want us to contextualize is independent research outside of the home health space, looking at what is the minimum gait distance that an individual needs to be able to complete to be, baseline community functional. That minimum distance is 1,000 feet. So that right there means, okay, when we start getting into 150 feet, 300 feet, 400 feet, those numbers are not what makes somebody homebound. Okay. Obviously, if they can walk 6,000 feet, we'd say, okay, this is really, really far, and most likely they're not. But let's not make it smaller than some of the research indicates you need to have to get back out into the community. That being said, this has to do with how easily could they go out and get this medical care? How easily can they go out for any event, whether it's to go to the doctor or to go out to dinner? So we look at this individual and say, okay, he has some cognitive issues, going to need supervision. That's something that is not going to be amenable to change. Okay, so if this supervision is in place, could he, without a huge issue, be able to go to a doctor's appointment? Now, remember, that means get ready to go to the doctor's appointment, go to said doctor's appointment, complete and participate in that doctor's appointment, come back, and still be able to function. So just because he could get ready with some supervision and we supervised him to the transportation, if upon return from the doctor, this person is now much worse, more confused, fatigued now, and now by the time we get them back up into their room at the ALF, they need to take a nap and 3 pain pills. This would give us an indication that they are homebound because this is not what should happen. We should be able to go and do something, come back, and still go about our business. So it's more comprehensive than can we do a certain distance in one shot, but we have to look at the whole journey that this individual would have to take. So based on this information, we can't take just one piece and say, well, he walked too far, or, oh, he has dementia, therefore he is homebound. That taxing effort piece is we have to look at the complexity of a task involved. Which, Sherry, one more piece I'd want to add, has to do with also looking at the living situation within the assisted living. So we may say, well, in my own home, it's X number of feet to get to my dining area. That can be vastly different in assisted living depending on what proximity your apartment was to the food source. So in some situations, it may be fairly close. In others, it may be way further to get to the dining area, to get to the door, to just get out. So we have to look at all of that and say, how difficult is it for this individual to go and do things and come back and still be functional? So I think, we want a nice, clear, thus saith CMS, but we have to look at the whole package of what a person needs to be able to do. And I think sometimes we boiled it down to gait distance or only looking at they could get to the transportation and not die in the process, therefore they're not homebound anymore, and not really think about the pre-work, the activity of being out and coming back and still be able to do what you need to do.
And Cindy, one of our attendees mentioned that, since the assisted living facility is considered their residence, would that make them qualified for home health? And I just kind of want to piggyback on what you were saying as far as the indication for the safety considerations for a person with dementia. I think that the documentation needs to be tight on what would happen if that person went out by themselves, because most memory units, hopefully all memory units, are locked spaces, and they've been deemed that they are not safe outside of a locked space. So can you speak to that and whether or not, they're considered homebound due to the assisted living facility, the memory care unit being their place of residence?
I'm just, and I know this isn't our unfiltered production, Sherry, where we get much more candid on our podcast, but this also isn't a pre-prepped presentation. So I'm going to be a little bit more blunt, I guess, than maybe I would be in other situations here. The challenge of this ALF is the reality that they are not regulated in terms of we cannot rely on certain standards of care to be across multiple ALFs. I have been in ALFs that are very tight things like you just described. Here's a memory unit. This is how we manage them. These are our protocols. This is our safety. This is what we do. I've been in ALFs where my patient had significant cognitive issues and memory issues, and this individual was placed in a first floor apartment across from a door to access outside that was kept unlocked. They felt this was, essentially independent living, and it wasn't their responsibility to create those kind of constructs. The family was paying for them to be there. They were being fed and monitored somewhat, but those extra pieces weren't required. So when we look at that ALF, we have to look at them individually like the patient. what is that situation? So if we're talking about that being definitive in our documentation, as you said, Sherry, about the degree of issue and what would happen and what supervision they need, we need to be vetting this for any patient in an ALF, not just the cognitive one. What is their situation? How much assistance do they need? Is that assistance being adequately provided? Because I've also seen yes, you went in there, you found out that they needed more support or more help. But we don't want you to talk to their family about this. You can't talk to their family about this. You need to talk to the administrator of the building as to whether or not that's going to be provided. I know this gets us to some tough conversations where we feel like if I push too hard, will they impede referrals to my home health agency going forward? But we always have to remember an ALF is a term, it's not a consistent institution, and it happens to be where this patient resides. So it's really no different in terms of what I need to do as that clinician and as the home health agency. The expectations on me are the same as if they lived in just an apartment building that didn't call themselves an ALF. So that's why there isn't a one size fits all response in this situation. Sometimes it works great. Other times I've walked in there and go, I think this is a fake nursing home. I mean, these people are not at a level of ability to be in some sort of assisted living. They need serious oversight. They need significant help. This one here is basically bedbound. This isn't assisted living. Oh, but we have this, that, and the other, and we take care of all of this. We always have to remember it's their home and we're accountable to the rules and conditions of participation surrounding the Medicare Part A home health benefit.
And it's part of our job on that first visit to qualify
Mhm.
them for receiving that care on that first visit. And we need to make sure that not only are we writing to the reg, but we're doing it specifically to that individual and not just recanting the reg in our documentation. Cindy, I want to move on with some pre-submitted questions if you're okay with that.
Mhm.
Okay, we're going to ask our attendees a question, and I hope that you'll answer in the chat or in the Q&A, either one. But what does everyone use as a resource or an app to look up medication categories for Oasis E? I know me personally, I'm a certified coder and an Oasis reviewer, and my favorite is my go-to is Google. And you can often find Kim. Thank you for putting Google because that's my best. I've got built into the EMR micromedics tip. We created a tip sheet. Google agency put together. Cindy, did you have a resource that's your favorite?
I'm going to go in your camp with respect to Google as a starting point to try to find a reputable source. I would say, the reason Sherry and I talked in advance about asking that question to you guys as opposed to us answering it is there's clearly not a one size fits all when it comes to dealing with this with respect to the item in Oasis E about high risk drugs use and indication. And what we're finding is agencies are kind of all over the place with respect to what they've decided the clinician should use, or in some cases didn't really decide and left it up to the clinician. So I see some of the responses, Sherry, have to do with it's already in my EMR. It's great. Some of the EMRs did that or had it already in place before or beefed it up a bit in preparation for Oasis E. But what I would strongly recommend is that whatever your organization wants to be the standard is what's communicated to the clinicians and reinforced in your review process.
Yes.
Because I think part of this is if you don't really tell me, then I'm going to kind of guess at it. And if anybody looked at the Q&As that came out from CMS this week, our first round of official 2023 Oasis ones, there was a good chunk of it related to this issue of how are you confirming pharmacological classification, indication, da da da. And I don't know. Love it or hate it, CMS responded to the majority of those Q&As by simply reprinting what we had in the guidance manual. So I don't get the sense, Sherry, on this particular point that we're anytime soon going to get a CMS says do this or use this. I think we should be grateful for that because you make it too restrictive, it gets harder and harder to try to comply. But I think we have to look at it agency by agency and say, what do we use as the standard? Does my entire team know that? And do I hold them accountable to our decision so that I don't have somebody going, I don't feel like looking. I know full well what that medicine's for, and I'm putting this pharmacological classification because obviously this is what it is. If you haven't confirmed that, or particularly the indication element, you don't want people putting down answers that are not supported.
That's fantastic. And Sarah, thank you for the drugs.com reference for that question because I'd forgotten about that. And that is a great resource. And it's up to date for the classifications of medications. Now let's go
Well,
to an
well, real quick, Sherry, though, real quick, Sherry, you touched on it. That is exactly why we don't want CMS to come up with a source,
right.
because it needs to be updated.
Yes.
And they're not really the ones who have the bandwidth to keep that updated with new medicines coming out sometimes on a daily basis. So we want to make sure we're utilizing reliable sources that are able to keep it current. And I think that's why pushing CMS too much about what do I do, what do I do, what do I do? I, I don't like seeing so many Q&As just being the original guidance repeated, but I would rather have them do that. We don't want to push them into a corner where they try to make one and then it's constantly out of date.
And or down, right? For maintenance on
Well,
some level.
true.
Okay, so I have an Oasis E question related to this. Patient is
Okay.
diagnosis from MD of DM, which is diabetes mellitus, is on metformin without indication in the documentation that it is for the diabetes. Can the patient be asked to verify that indication for response to the high risk indication?
Okay, so first of all, I'm going to probably sound a little bit like CMS because that a variation on that question is exactly what was in the Q&As that came out this week in terms of it looks obvious, can I ask the patient? What they go back to is the two-pronged approach in the guidance, which is for indication, they give us a litany of documentation sources for indication. So they talk about the referral, they talk about the H&P. Based on other Q&As, we could or could not use the information, documented information that comes with their prescriptions from the pharmacy if it meets the intent. That's what they keep going back to. Does this idea meet the intent of the guidance? And the first prong of that guidance is documented indication. The second point says you can seek verbal clarification. You can talk to a referral source. You can talk to a caregiver. But the crux of this matter is, do you have documented indication for that medication? So based on that original guidance, based on the way they repeated it in these Q&As, documentation appears to be what we are looking for first and foremost. We can supplement that documentation about indication with further clarification and discussion, but it does not state we can substitute what the patient said it was for what the physician ordered that medication for. So I think what it comes down to, Sherry, and I will try not to go too soapboxy or consume too much time with this. I think the issue with that indication, the first column, pharmacological classification, yes, we know it is the technical designation of the medication. It is independent of what the patient might be using it for. It is strictly what is that class. So we can find our sources. We can go to drugs.com. We can get it. We can put our check marks accordingly. The second piece feels very much like process measure questions that we have or have had in the past, where we do not like to mark no, because we feel that putting no about giving a vaccine, no about two-way communication with a physician is somehow a negative, it's a bad, it makes me look bad, and so I don't want to see that answer. What we have to understand with this new question is, it is simply a data collection discipline neutral tracking question about, are we seeing patients who take medications in these categories? And when they do, is there documented indication for that medication accessible? If I've looked through the sources they've given me options to consider, and I don't find it for every medication that landed in that group, I need to leave indication blank. I just need to do what the directions tell me. Because my concern, if we look at historical activities around process measure questions, we overwhelmingly mark them yes. Okay, all right, Fall risk assessment, I understand that. We had a tool embedded. We were doing it so frequently that CMS took that question out in Oasis E, because what's the point of asking you a question that at nearly 100% of the time you say yes? However, we've also seen in the two-way communication with the physician about a medication issue, an overwhelming amount of yes there as well. So we're telling CMS that when we do find a clinically significant medication issue, we do get two-way communication from the physician within 1 calendar day. So when we go back to CMS and say, listen, this is really hard to get the physician to respond this way, and it's unfair that if they don't respond to me, although I basically stalker called them for the whole day, I still have to put no. What they do now is they look at our data and say, I understand what you're saying, but the industry data says this is not a problem. I've been in the room when they've done that. My concern with this one is we have to be prepared to not check the indication box if we don't meet the criteria that's in the question. And we need to be okay with that. Because ultimately, if we're going to come back and say, look, we can't find indication on a good number of these. Okay, we don't write the indication, the physician does. That's got to come from, okay, now we need to work on this. We need to work on this and figure out a better way. Or is there something we need to do differently with the physician? Or how are we going to work to address this? But if our baseline data comes out with every time we find something in these classifications, every single time, every single med, we always find an indication. We go check, 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 check all the time regardless. CMS believes you. And then when we say, hey, we need to do something about this, they're going to say, do something about what? You reported to us that you always find the indication. So I totally get it that we don't like this idea of leaving that blank. Someone asked me just yesterday, what's my liability if I don't put a check mark there? Okay, well, take it down a notch. Discipline neutral data collection. You asked me to look for certain things. You told me where I could potentially find them. I did. It's not there. Box is going to be left blank. And I expect my clinician to tell me, I looked here and here, could not find it for this, or there were 2 opioids, I found it for the one, I did not find it for the other, that's why it's blank. And we move on, because then we'll ultimately be able to see what our data looks like and say, what are we going to do to remedy this situation? Or is it really true that we can find indication pretty simply, and this is a non-issue? So I know that's a bit longer, Sherry, but I feel like the undertone of what about this? What about that? Can I do it this way? Can I do it that way? CMS keeps coming back with, does it meet the intent of the question? And the intent is, did you find documentation of an indication for all drugs that landed in that pharmacological classification? And it flat out says, if you don't put a check mark.
So I think that one of our listeners here had a great suggestion. One of the things is if we mark if we cannot if we mark that we can't find an indication, is it a best process to contact the provider to get the indication in writing? I think that a verbal order is sufficient as long as that verbal order is written appropriately and then sent out for signature later. Cindy, what do you think?
I think anytime we're trying to remedy something, be it this issue, be it, I went out and I found a primary, the primary reason for care does not align with what the physician sent over on the referral, so I'm going to call the doctor to resequence. Yes, a verbal order can work for that, but it has to be written correctly. It has to specify who you talked to, what the discussion was, and clearly what the directive was about the intention for that specific medication. I believe if we have, again, we're going to play CMS. If that's written and eventually signed by the physician, so we know what date this verbal order was given and all of that, then yes, that meets the intent of the question. But if it's some generic called physician and reviewed med profile, oh, see, I got it. Now I picked indication. That's not the same thing. It would have to specify what we're talking about.
Thanks, Cindy. That was a very complicated issue, and I think that we need to stay abreast of the Q&As as they come out to make sure that there's no further classification, because this appears to be one of the things that the folks that write in the Q&As to CMS are going to ask this question probably 50 times in 50 different ways, right, Cindy?
Yeah, but like I said,
Yeah.
it's the let's take the emotion that can come with Oasis, take a step back and say, what do we pull out of this? Does it meet the intent? So if
Right.
I can see clear documented evidence that this is what that medication is for, I can't do it. I can't say you have diabetes, that's metformin, it's for this because I know. I'm not I'm not the deciding factor here. So I've got to find it somewhere that somebody knows why they gave that medicine. So it's one of those situations. We may find over time that this smooths out, or we've got a good, referral format and it's listed on there, or we pulled it from the pharmacy information. They've given us a lot of places to look. But at the end of the day, if it doesn't meet the intent, I got to leave it blank, and I'm going to document, what happened with that. But I also, again, I cannot stress enough I'm going to find every way to interpret it so I have a check mark every single time. That could come back to bite us if it's inaccurate.
And one of our listeners asked if diagnosis association is the same as indication, and it's yes. If they say that they are taking metformin for diabetes, then that is the indication of that medication. The other thing is that someone wanted you to clarify, would you put no or no information on that item?
It's hard to, okay, let's back up. I cannot, in isolation, look at somebody's diagnosis, look at a medicine, and draw the indication line.
Right.
This is why that question is so specific about you put it in the pharmacological classification that's designated for the medication, which may not even be why they're taking it. So we can't draw the line. If I don't have it, you have to understand there is no option. It's a check mark. It's putting a check mark that means, yep, everything in that group had it, or leaving it with no check mark because you didn't. There is no option. Um, Insufficient data. I mean, I have to go back and look. We're not seeing a lot of discussion about dashes, and dashes are meant to be a very infrequently used item. While you go to the next question, Sherry, I can take a quick peek on that. But it's simply, if it's not all there, the directions say leave it blank. There is no option.
Thanks, Cindy. I appreciate that. And I'm going to move on to the next question while Cindy looks up that one to make sure that we've fully answered that question. Okay, so we've been sent a referral. I grabbed this off the knock listserv because it was such an interesting question to me. We've been sent a referral for a patient who needs 24/7 vent support at home. Does your agency need special certifications to be able to accept? And has anyone had experience with this type of care in home health? I am sure that some of our 150 listeners right now, attendees right now, have had some experience with vent care in the home. But the thing that jumped off the page about this question for me, Cindy, was 24/7. One of the things that home health is, one of the things to qualify for home health, it cannot be 24/7 medical care. Correct, Cindy?
Correct. I mean, we aren't a total care operation. It needs to be the need for care on an intermittent basis.
And I would indicate in this situation, if you're looking at a Medicare patient, it would be very difficult for you to be able to support that from a financial perspective, to have someone in the home like an LPN or even a CNA 24/7 and then have your medical care as needed. I know that there are some Medicaid waiver programs that offer 24/7 vent support in home. And that's the route I would take with that. If you receive this type of a referral, I would look to see what other programs are around that provide that support of the 24/7 care. But I'd be very hesitant. I know we're talking a lot about hospital at home. Just be aware of what the COPs and what the survey set and all those things say about what home care can and cannot support. Cindy, did you have anything else to add to that?
Um, Not at this time, but I do have a quick response back to what we were saying before.
Okay.
Um, Technically, you can use a dash. I will say though that every example that they provided in the guidance, when it says you couldn't find it, tells you to leave it blank. So they expect dash to be a rare occurrence. So it's one of those, if I've looked in those sources and there is no indication noted, blank is what they're expecting to see.
Okay, I think we put that one to bed. I have one last non-Oasis E question, and I'm very excited that we got through a half hour of this Q&A without even starting Oasis E, but we do have a half hour worth of questions. And if anybody has any Oasis questions, now is the time to submit them via the Q&A. Obviously, a lot of folks are using the chat, and that works as well. So if you have any other questions that are top of mind, please feel free to submit those so that we can get to those. Last non-Oasis question. Do we have any updates on the required 30-day therapy assessments for home health therapists?
Well, I guess the only update would be that we are seeing a resurgence in external auditing. We're seeing folks ending up with requests for ADRs. We're seeing RAC return. We're seeing TP&E resurgence. So you may say, well, that didn't answer the question, Cindy Kraft. No, but it gives us context. The issue of the therapy reassessments appears to be a prime target of these entities with respect to looking for a reason to deny. Why? Well, historically, they'd like to look at therapy because prior to PDGM, if they could disallow even a portion of the therapy visits, they could drop it into a lower reimbursement group and collect the difference. What they're doing now with the therapy reassessments is a lot to do with the fact that they line up to every 30 days. And we now are in a 30-day payment period environment. So if I hone in as an auditor to that therapy reassessment at the end of that first 30-day payment period, and I don't find that it met the expectations, then I can disallow all the therapy visits in the second 30-day based on not complying with that therapy reassessment issue. Now, many of you will say, we've been compliant with that for years. Are you sure? Because compliance is not just, did I do it in the right time frame? We're seeing a definite holding feet to the fire about what is the content in terms of, can you clearly see subsequent objective information compared to where you started? So this is not just, I started out walking 20 feet, now I walk 50 feet, the goal was 100 feet, plan to continue. No, we're not talking about just sticking numbers in a reassessment. It's saying, how do I know whether or not the therapy's been effective? In order to make that decision, if we took the requirement aside, if I'm a therapist deciding, should we continue care? I need information. I don't just say because I have an order, because I like this lady, because they're close to my house. No, I have to look at my patient and say, all right, compared to where we started to where we are now, how do I know if this has worked? What things are they doing better? What things may have stayed the same? What things are not where I thought they would be? So I get that data, and then I'm going to interpret that data. And I'm going to look at it and say, this is how I came to the decision. This is working. We're going to continue this. This needs to be adjusted because we're not going at the rate we thought we would be. Or the plan needs to be tweaked because what they're presenting like now is different than where I thought we would be. That's what you have to see in a reassessment. That has been the expectation since day one. Even back when it was 13, 19, 30, all that rigmarole crazy math, the expectation of content has not changed since 2011. The issue is the diligence about denials was more about taking out therapy visits for the reimbursement issue. It's now pivoted to another reimbursement issue based on the 30-day payment period. So the expectations are absolutely no different. The concern is we've gotten lax and we've created reassessments that just say continue the plan I already had, continue per physician order, continue per POC. That doesn't say how you came to that conclusion, and having an order is a technicality from a compliance standpoint, but a doctor's order doesn't mean this care is necessary. I have to speak to that and really look at, does this person need to continue care? And so what concerns me as I do documentation audits is overwhelmingly these reassessments do not change anything about the plan of care, ever. The goals, the interventions, frequency, nothing, ever. And that's not possible unless you guys are psychic and want to go buy some, lotto tickets and see how well that works out, because any discipline is basing a plan of care at the information you have at the time when this started. How this patient does over time can vary greatly in some situations. They do better than we thought. They do worse than we thought. We had something flare up that we weren't expecting. This caregiver changed, all of these things. So we're just going to keep telling CMS that that plan we write at the beginning is always exactly what we're going to execute, unwavering, and we're to continue because we have orders. Not a strong case. And as I said, Sherry, with the uptick and resurgence of auditing, I think we're going to see more of this be a preferred target because it literally does kick out the coverage of all the therapy visits for that discipline that go into the next 30-day episode.
I agree 100%. And this is a big reason why we need to make sure that we comment on any proposed rules that come up in home health, because this feels like a vestigial limb to back when we used to count visits or count number of episodes that a patient would see somebody. And I think that its time has come and gone. However, it is still a requirement, and we need to make sure that we're meeting the bar when it comes to what that requires. All right,
But Sherry,
Cindy.
I would argue we have the same issue at recertification. Because how many times do we look at a plan of care and okay, we're going to do 60 more days. The goals are the same, the interventions are the same, the frequency is the same. There's minimal change to this plan. So wait a minute. So you wrote a plan, you worked that plan for 60 days. It didn't work apparently because these are the same goals and same everything else. And you just think you get 60 more days to keep trying? I mean, recertification is another great time point to say, how do I know what's working? What isn't working? What jumped in unexpectedly? How does this change what I'm going to be doing with them? What did they learn in this episode? So I'm not going to go back and keep teaching them the same thing about diabetes for another 60 days. So I think this is, although it can feel like therapy got hung over on this piece from days gone by, I argue that anytime I'm saying we need to continue, there has to be objective information and clinical decision making behind it, not just the doctor was willing to sign another plan of care so I can go for 60 more days. I mean, that's why when we audit multiple episodes, you can see strength in that first 60 days about why am I here and what am I doing? And then you find a recert and another recert and another recert of you're doing the exact same interventions you were doing 6 months ago and you're going to keep trying? I don't understand. So I agree that this feels still back to the counting of therapy visits, but I think it's a great wake up call about what's going on with our research in general.
100%. And one of our attendees today asked, "Do I need to have new or updated goals for a 30-day reassessment? Have we heard of any denials because new goals were not included in the frequency order for ongoing therapy?" I'm going to start. I don't think you need new goals, but you do need to state the progress to the current goals and adjust goals accordingly. That's that skilled part, right, Cindy?
hmm Well, and I think the blanket statement I see far too often is patient progressing toward goals. It doesn't say which ones, it doesn't say to what degree. So it's not about, oh, so what I need to do is jazz up my plan at the reassessment so it passes muster. No, they're just looking for what is your justification to continue?
Right.
And yeah, that feels intrusive, but at any point in care, regardless of discipline, somebody should be able to ask me, why are you still seeing Sherry? And I should be able to tell you. If it's because I have an order or because I like going to her house, that's not a reason. If I can't come up with a viable reason when I'm asked by anybody, then we have an issue of whether or not this service is really skilled, reasonable, and necessary.
100%. And so we're going to go into Oasis E section of our Q&A. Here we go. Does CMS have a regulation for timeliness of Oasis documentation?
Well, I'd almost, Sherry, want to put that back to the group because there is nothing new with respect to the timeliness issue. That we know that's a condition of participation timeframe, that it is supposed to be accurate, completed, and encoded and sent within 30 days of the completion of the assessment, the M90 date. So there hasn't been any change. I know there's some, with the waiver and we could turn things in, but fundamentally, we have that standard coming from the conditions of participation of when this information needs to be in their hands and considered blessed, final, and fixed.
And I want to also indicate that we need to make sure that we're using that 5-day period to gather the data on this patient. Most of the time when we're doing assessments of Oasis completion, we're seeing that the M90 date is matching the start of care date. And that just tells CMS some wrong information, doesn't it, Cindy?
Well, again, we would never suggest people inflate it, but those situations where I do need to follow up with the physician within one calendar day. Let's just say, just use that one as a simple example. So I go out and I do my assessment today. I find a clinically significant medication issue and I call the doctor. Doctor calls me back tomorrow and we reconcile this situation. We decide what needs to happen next and away I go. The date assessment completed is tomorrow. It's not today because tomorrow is when the loop was closed and the physician did get back to me. And this is when we then followed up in the parameters of that question. So I get confused when I see a lot of yeses and then the 90 date always matches the start of care date. So they called you back right then. I mean, they could have, but those situations where I'm going to collaborate with another discipline before I choose a final response, those kinds of things that indicate I need more information before I land on my assessment answer do need to be captured in M90 because that's another great question, Sherry, that when we tell CMS how awful this is and how long this takes, and it takes me days to, get all this stuff in order in terms of the assessing clinician, not the review process, not until I turn it in. We're talking gathering data to choose responses. CMS looks at it and says, I don't know why you complain because overwhelmingly you're all getting it done the day of the assessment.
That's a shooting yourself in the foot, basically. That's what we used to say, but when you're your own worst enemy. Second question is our favorite, Cindy. How much longer do you anticipate an admission will initially take for staff?
Okay, so we've moved into now reality in terms of forecasting. And forecasting was getting a little scary. And some of you probably heard that on our podcast or other things we did that was really pushing the 4-hour admit. What we're seeing now in early 2023, and we know that we expect a learning curve. So January should be the worst. And then we start to see improvement February into March because we're going to find our footing. I mean, no matter how much prep we do, no matter how much information we provide, the clinicians individually are going to have to find their flow for this and be able to say, how am I incorporating the interview questions? How am I doing this? How am I doing that? And then over time, this just becomes more routine because it's more familiar territory. What we're seeing right now from our outsourced coding and Oasis review clients is they're reporting about 30 minutes longer of actual in-home time. Now, that's an average. Some of it might be a little less. The patient wasn't particularly complicated. It could be more than that. A few things to consider. Again, knowing that January is going to be the most volatile month, we also need to organizationally watch that this starts to go in a better direction. So I would watch for two things. One, do we have somebody whose visit length has gone significantly up and stays there through the first quarter? Because this might be a situation where we need to go out on some co-visits and figure out how to help from a strategy standpoint to incorporate this in maybe a different way to expedite this process. I would also watch individuals whose visit length isn't any different. And we're starting to see that as well. Or some clinicians, their admission visit length is not anything different than it was prior to 2023. Our reviewers have voiced some concerns on that front to say, with so much of Oasis E new items being interview, and that means I have to literally interview the patient and get their answer to choose a response. Our clinicians trying to cut corners answering these questions later, which isn't going to work from an accuracy standpoint. I can't answer something later. Why? Either I'm doing one of two things. Either I'm writing down an answer and double documenting, which is a waste of time, or I'm winging these questions and coming up with answers outside of the visit, which is definitely a risk factor for accuracy. So I'm not one to say, 30 minutes is the gold standard or, it's this or it's that. I think we need to look at our teams and say, all right, bumpy, but where are we going from here? If somebody's too low, I'm going to question it. If somebody's really high and stays there, I might want to do some work on that. But really make sure that those interview questions are being done the way they're intended. And I've stressed in our educational efforts, why would you make this harder on yourself? It's a script. Read the script, use the answer you've been given, and over time, that will find its groove with respect to how we do it. But, if we're seeing situations where this is, doubled the visit, tripled the visit, I, again, I'd be patient with it a little bit in January, but then I'd want to dig a little bit deeper and say, what's going on with this really? And Sherry, the piece I'd like to add to that is we're seeing activity about, how many points are you giving it now? Or we've upped the points, we've changed the points, we've fixed the points because of this. Again, we're not reimbursed per visit. I don't want to provoke you too hard, Sherry. I know that the visit thing is a passion area of yours because we're paid episodically to manage a patient. We're not paid per visit, but productivity is visit driven and is still part of our vernacular and how we manage how we do business. But I'm just going to say, been in this space a long time, if I'm really going to now say you get 4 hours between the visit and non-visit time to do an admission, which means you only expect me to do 2 a day to be considered productive, there's also an unintended potential consequence that I'll stay slow because I'd rather just do 2 admissions a day than potentially 3 or 2 and a couple of routine visits. So again, we do want to watch our own data. And even if it does line up with some magic number you see in an article, I still would take a look at it and say, what's going on with individuals, particular disciplines, where are we trending over time? And have I inadvertently incentivized people to be slower and stay slower when maybe we need to revisit that in the second quarter of 23?
And I also think we need to be very careful that when we compare ourselves to quote unquote industry norms, and understand that some places, some geographic locations, there is a mileage of,
Mm-hmm.
some providers only do 10 miles a day to see a full caseload. Some of you are just like in shock that that is actually true, but it is true. Some folks in some of the inner cities don't drive at all. They literally walk to all of their home health patients, and there's no mileage and very little time in between patients if they're in the same independent living or residential apartment building. So be aware of what those mitigating factors are for your agency and decide on your productivity. And I'd love to see a metric, Cindy, and maybe we can come up with it through our studies that shows what a clinician can do appropriately over that 5 day period. Because if you spent an hour on an aspect of a start of care, how many starts of care could be appropriately done in 5 days versus the 1 day? Because if we're encouraging the use of that 5 day window, it's super important that we look at that as part of our productivity standard. I want to move on to another question. Is that okay?
Mm-hmm. Yep.
Okay, this one it was submitted by one of our attendees today, but it sort of matched another question that was pre-submitted. Could be the same individual for all I know, but how are other agencies handling discharges being done not during a regular visit? For example, the patient refuses DC and you have to DC off of your last visit. How are you capturing the TOH info? How are you getting those things that are the interview and have to, like the BIMS, the CAM, the PHQ-9, health literacy, and all that? How are you getting all that data, and is it appropriate to get that data over the phone?
Well, here's the situation we find ourselves in. The rules around a non-visit discharge didn't change for E. So I'm in my situation of backing up to the last visit done by a discipline that could do an Oasis, and then I can consider information between that and the discharge. But if in that time period, I did not administer the BIMS, I did not ask some of these questions, then I'm going to be left with a dash of not assessed in the questions that allow me to do that, because I cannot now just ask you a bunch of things over the phone. And since that was a pre-submitted question, Sherry, I went back and dug through the manual on these, and the only paths they give us are sitting in front of the patient and verbally asking them, or scenarios like the BIMS, doing it in writing. I can't find anything in here that says go and do it over the phone. And so I think that that's something, based on what we know today, those are items we could not respond to because we can't retrofit that in there. There was no direct visit in which that information was collected, and that's what our standard is. Go back to that one. We can look at what happened by other disciplines in between, but it has to relate to the question. If it's an interview question nobody asked, then I don't have that information. And so I think that's, again, that's what we know today. It's still early in January. We've never seen as many interview questions as we have in this particular version of Oasis, and many of them specifically say you have to say these words and do it in this order. I think that would be a great submission for a Q&A to say, what specifically can we do in this situation? Because again, the manual is going to address what they believe is what usually happens, and it is usual that we're discharging somebody and we're there, but these situations do arise, and previously we didn't have to interview them on stuff. We could infer it from other areas. So I would highly recommend that that question get sent to the CMS mailbox for this, and then we see what happens in April.
And in the chat box, one of our attendees has thankfully put what they got as a response. And if you're not able to get the information, when you haven't completed those interviews within the last 5 days, then dash is the only appropriate answer or only allowable answer. So if you guys refer to the chat box, you can copy and paste that into a Word document and keep it for future reference if you have this issue come up again. Is it true, Cindy, that the follow-up Research Oasis no longer needs ICD-10 codes? If it is, what happens with the plan of care and what about the resumption of care?
Okay. Once again, the mantra with Oasis is discipline neutral data collection. All that happened on the research is they removed questions 1021 and 1023. From a research standpoint, Oasis doesn't want the diagnosis information. I'm not shocked because when they look at our diagnosis information with respect to payment, they're not pulling it from 1021 or 1023. They're taking it from claims data. So I think the only reason it stays on starts and resumptions is because they're looking for consistency, but ultimately they pull it from claims data. I'm not saying that means we just put whatever we want on start or resumption, even if it's inconsistent. We want it to be consistent. But specific to research, they simply removed the 2 items. This is not an emotional thing. It doesn't mean they don't care. It doesn't matter. It simply means there's nowhere for me to put it. However, we know that at the time of research, sometimes the primary and relevant secondary stay the same because this really hasn't changed from a diagnosis standpoint. Sometimes it can be significantly different. Okay, something has happened, something is resolved, and we resequence and all that. That should still occur. That occurs by virtue of our plan of care. That would absolutely have to involve the physician if I'm moving diagnoses around and saying this no longer is the focus of care. Yeah, I would have documentation about that conversation. I would have documentation about my clinical decision making and my rationale for, let's say, this is what needs to be different about my plan of care at the time of research, or why these diagnoses are staying the same as we go into the next 60-day episode. What we do with the diagnosis in terms of representing the patient, especially because we're going into a new claim in these new 60 days, absolutely still occurs. Hasn't changed anything about it. All that happened is they decided they didn't need that information in the actual Oasis. So for those that feel they still need it there and they still want a place to put it, you can put it in your note wherever you want. It's simply that CMS said, for our data collection purposes, we don't need it as an item. So it's not a change in anything other than I don't put it in 1021 or 1023 because they are not on that form anymore.
Cindy, I have another great question, but I want to remind folks that if you have any questions, please submit them or you can get in touch with us via our email addresses, which will be on the last slide. But when is a good time to do an audit, everyone? One of the things that we're recommending folks early on in the Oasis E process is if you do a quick audit of what you're doing in the month of January, for example, that is a great way to get ahead of some of the issues that can become ubiquitous to practice. You don't want habits and bad habits to become the norm. So make sure that you take the opportunity, get an audit, if not through us, through another reputable vendor and or in-house, and look back at what you've done in the month of January and make those improvements earlier. Cindy, going back to the discharge question, what about if a 2-year clinician, an LPN, PTA, CODA, got information that is relevant to the discharge, such as they perform the BIMS or something along those lines as part of their care? Can that data be used when doing the non-visit discharge?
Again, we go back to what are the rules around a non-visit discharge is that we back it up and then information from other disciplines, even the ones not able to do an Oasis, if that information can be found in those last few days, yes, we can utilize it. But I would be shocked if an LPN randomly did the BIMS without direction and then we ended up unexpectedly discharging somebody. I mean, it could happen, but what I would hate to see is we try to say, okay, so to avoid ever having to put a dash on a non-visit discharge, let's just make sure people ask them these questions every single visit. Now, that may seem extreme, but that's what we've done with homebound status. We've made it an every single visit issue as a precaution. When the rules don't state it has to be stated every single visit. So let's just, there's going to be situations when I try to get out there. They absolutely refuse to let me come back. This is what I have to do. Nobody asked them. Dashes are going to be there. CMS expects it to be a rare occurrence, just like they expect a non-visit discharge to be a infrequent event. And so I would also, much like Sherry said, looking at data, I would always be keeping an eye, tracking and trending these non-visit discharges, because sometimes, I'm going to speak as a clinician, if we're really busy and this person is hemming and hawing about a visit, I don't really think I need it. Am I really going to push it to say, I need to come back out one more time to do a final assessment? Or am I going to say, oh, he doesn't want me to come because then I can go take care of some other things and do more visits and don't have this on my schedule, and then we'll deal with it later. Because I think sometimes there's a scripting element that facilitates a patient deciding they don't want us to come back, along the same lines that can happen with missed visits that I, as a previous rehab director, started to notice, boy, we have a lot of missed visits that happen on Friday. Um, was this really a you don't want to be seen, or I don't feel so good, oh, why don't we do this next week? So again, devil's advocate a little bit, but that non-visit discharge really should be an infrequent to rare occurrence.
I agree, Cindy, because wrapping up that care, and especially as we get into value-based purchasing, it's super important that we get some good
Mhm.
data and reliable data to provide for how we've done with that patient during the time we've had them under care. Last question, everyone. I know this hour flew today. Oasis E, at the agency discharge visit, the patient's PIC line is removed. How would you score 001, I'm sure it is, 0110 special treatments IV?
I'm a little brain dead, Sherry. I would like the opportunity to go take a look at that guidance manual, and then we can put that out in the next newsletter as a follow-up to one of the questions there. And this is why I never claim to, wear a wizard hat and know all of this off the top of my head. And I would absolutely hate to misspeak and cause additional confusion downstream. So I'm happy to go back, research that question, and then you can put it in the newsletter or whatever platform you see fit, or maybe with the recording of this, because I don't want to leave that hanging, but I would hate to misspeak.
I agree. And as we're at the end of this, I wanted to make sure that everybody noticed that we put up the slide with our contact information. If you have any additional questions that came up or one that comes up later, please reach out to us via email. We like to answer questions. We like to give you the regulations behind those answers so that you can use those going forward. And I just want to say thank you again for attending our live session for the Q&A. This was a very good session, but you will be receiving the recording of this session, and you can use it at your leisure, and or you will find the recording on our YouTube channel. If you've not already subscribed to our YouTube channel, I would highly recommend that you do. Anytime that we have new free information and the ability sometimes to speak off the cuff in our unfiltered podcast, if you haven't had an opportunity to listen to any of our unfiltered productions, they're a little bit entertaining because you get to hear Cindy and I without that professional veil and some of the issues and hot button stuff that comes up on a day-to-day basis. So if you have any further questions, please reach out to us. And thanks again. We'll see you again in March. I don't know exactly the date, but you can find it in our email blast. And if, again, please reach out to us at our emails if you have any questions. And Cindy, one last thing before we go. I have more gray hair than this in this picture.
I'm pretty sure I do as well, but we'll leave these there. I like these two pictures.
I will leave this there for the rest of my life so that as I age, it won't age at all. So thanks, everyone. We'll see you in March.